Okay, Assalamualaikum warahmatullahi wabarakatuh and very good morning. Bismillahirrahmanirrahim. So we're going to start because it's already 2 minutes past 8 a.m. So today I welcome you to the CPC from Ortopedik Department, specifically by the Pediatrik Orthopedic Unit. We are going to discuss or present a rather complex case in the sense that the complicated or long history of disease and also management. However, we're going to focus on the area and some areas and highlight on how we get into the diagnosis, which would benefit the students, and also some parts of the management, and in the end, the discussion of the current problem, which is the large bone defect. So we have here Dr. Adli and Dr. Alexander and Mr. Fazli from Orthopedics and Dr. Juliana from Radio Department, and also Dr. Said Nabil and Prof. Rina from Pathology. So without further ado, I invite our first presenter, Dr. Adli from Orthopedics. Please.
Okay, Assalamualaikum and very good morning. I'm Dr. Muhammad Ali, Medical Officer from Orthopedic. So now we start with the case presentation, the history of presenting complaint. This patient is 10-year-old girl with no known medical illness. She was presented with complaint of pain and swelling of the right shin following fall back in 2018 at the time at the age of 8 years old. The parent brought her to seek medical attention and was treated with soft tissue injury at the time. However, the pain was persistent despite the analgesia. The pain was localized over the right mid-shin region, and the child walked with a limping gait because of the pain. Otherwise, there's no loss of appetite, no loss of weight, no fever, and also no night pain. Besides that, there's no history of the recent URTI, UTI, or AG prior to the symptom. And there was also no history of lethargy and no easy bruising. A little bit about the antenatal history. Antenatally was uneventful, and the mother has no medical problem during the pregnancy. And the child was born via spontaneous vaginal delivery, and it was uneventful with birth weight 2.8 kilogram. The developmental milestone also is up to her age, and the immunization is complete. For family history, patient is a second child and has one older brother. There's no family history of same presenting illness and also no malignancy run in the family. On physical examination, the child was generally normal build up to her age, and on local examination of the right lower limb by the inspection, there's a vague swelling over the entire aspect of mid-shin. However, there's no skin discoloration, and there was no dilated vein, redness, or punctum overlaying the skin. And on palpation, the swelling is hard in consistency. However, it was non-mobile, and there's a tenderness along the mid-shin. There was no lymph node were palpable, and other systematic review was unremarkable. This is the blood investigation was done at that time with full blood count. The patient total white is 13.2, hemoglobin 13.4, and platelet 248. The CRP slightly elevated to 5 and ESR also elevated to 40. At this point of time, based on the history and the physical examination, this is the differential diagnosis that we obtained. The first differential diagnosis is possible infection, which is such as osteomyelitis. Osteomyelitis is quite common in children. However, in this case, this patient doesn't have any history of fever, no present history of URTI or UTI symptom prior to the onset of the pain. And on physical examination also is unlikely to have infection because there's no redness, no worm, or no formation of abscess over the affected area. The second diagnosis is trauma-related, such as fracture. It is possible because the patient have a trauma before. However, patient still able to walk even with the limping gait. On physical examination also, there's no sign of the trauma such as bruises, no hematoma formation and all that. Okay, our third diagnosis is soft tissue malignancy such as rhabdomyosarcoma or neuroblastoma. It is quite common at this age. However, it was unlikely because usually the soft tissue sarcoma, the swelling is occur first before the onset of the pain. And on physical observation also, there's no dilated vein or the skin changes overlaying the skin, and the swelling is non-mobile, is quite fixed to the bone. Our fourth diagnosis is bone malignancy, such as Ewing sarcoma or osteosarcoma. Ewing sarcoma is quite common at this age. However, there's no constitutional symptoms suggestive of malignancy. And while osteosarcoma, it uncommon at this presenting age. It usually happen in quite older child. And our last diffusion diagnosis is hematological malignancy such as leukemia. However, there's no sign of anemia or easy bruises suggestive of the blood disorder. So this patient went to private center and further investigation was done there, including the MRI and also X-ray of the right tibia. And they proceed with the PET scan also and find out there's an increased uptake over the both of the tibia, which is right and left, with soft tissue intention. So they proceeded with the plain radiograph and also MRI over the left side as well. And subsequently, they proceed with the biopsy of the bilateral tibia, and the case was referred to HCTM for further management. Okay. Now, I would like to invite Dr. Juliana to discuss about radical finding, followed by Dr. Sheikh Nabil to discuss about the histopatho finding.
Okay, Assalamualaikum and a very good morning to everyone. First of all, thank you to the organizing committee for inviting to today's CPC. So the outline of presentation will be divided into two parts. So we will touch upon the Ewing sarcoma first, and then later on we will look at upon the fractures, okay? All right. So Ewing sarcoma is a group of small round blue cell tumor. It's the second commonest primary malignant bone tumor in pediatric age group. All right. It will tend to have aggressive permeative osseous lesion. You will tend to see cortical break as well as soft tissue mass. Later we will see regarding the Ewing sarcoma. But look at this diagram. This is to show the predilection of location of Ewing sarcoma. It tends to be in long bones diaphyseal in location, or sometimes it's metadiaphyseal in a location as well. Flat bones we commonly seen as well, especially at the iliac bones and the axial skeleton. When we talk about Ewing sarcoma, we normally always differentiate it with osteosarcoma. So the striking features of osteosarcoma, it tends to be intramedullary in origin. So you can see here tumor depicting in the intramedullary and elevated Codman's triangle is seen here. But in Ewing sarcoma, they tend to be in younger age group of less than 10 years old, as our patient as well. It is located at diaphyseal in common location with this typical lamellated periosteal I will show you the image later, and it tends to have this eccentric soft tissue tumor, okay, as opposed to the osteosarcoma. So when you see this diagram here, you can see the nature of the growth of the soft tissue tumor in Ewing sarcoma patients. It tends to have this permeative osseous lesion, as I mentioned before. There shouldn't be any sclerotic margin in typical cases, and aggressive bony lesion tends to have wide zone of transition. So what is wide zone transition again? So we cannot draw any margin to the tumor. So it is called wide zone transition, okay, as opposed to narrow zone transition. It is of permeative nature, and sometimes in radiographic findings is very subtle, as you can see only ill-defined lighting lesion, or we call it moth-eaten appearance. Okay, so in Ewing sarcoma, it tends to have no tumor matrix within, as opposed to osteosarcoma, it tends to have this cloud-like appearance or osteoid matrix within. Okay, and as I mentioned before, the typical periosteal would be onion peel appearance or lamellated appearance. And occasionally, in early stage or in the slow, because the Ewing sarcoma tends to be a bit slower the process, the findings is less aggressive in the earlier stage. Okay, so this is not our patient, but this is a very typical case of Ewing sarcoma in our center. So the solid arrow here is showing you the lamellated periosteal reaction, as you can see here at the diffusor region of the humerus. Here, there is a large opacity, soft tissue mass that we expected in Ewing sarcoma typically. And this dotted arrow here is showing you the ill-defined lytic lesion, and this is a typical Mauve-Etienne appearance here in AP radiograph. This is just to depict the concentric rings. You can see the alternating low signal intensity, hyper signal intensity, low signal intensity, concentric rings of appearance of lamellated periosteal reaction resembling an onion peel appearance. So let's look at our patient. So this is AP radiograph as well as lateral radiograph, and you can see here the abnormality is depicted at the metadiaphyseal of the right tibia. Okay, in close inspection, you can see from here there is cortical break at the medial aspect of the tibia here, with periosteal reaction, elevated periosteum at the superior margin here as well as the inferior margin. Osteomatrix is a big cloud-like, and where the mixed sclerotic or osteoid formation can be present 40% of the Ewing sarcoma. It is wide zone of transition. You cannot draw any line to it. So this is typical of aggressive bony lesion. Let's look at the MRI first. In this T1 sagittal here, normal marrow signal will be hyper intense, which is white on MRI on T1, resembles the normal fact. But what this bony lesion has, it has replaced the marrow signal, the normal marrow signal, with low signal intensity here at the location of metadiaphyseal of the tibia, and the arrow is depicting the cortical break. Okay. On this T2 fat saturated axial sequence, you can always see the concentric rings to look at the lamellated periosteal reaction, low signal intensity, hyper signal intensity, and low inner cortex here. And there is also evidence of cortical break, as you can see from the sagittal as well. This outer edema of fluid sequence, hyperintensity, is showing you the edema surrounding the bony lesion. On this post-gadolinium or post-contrast coronal as well as axial, you can see enhancement of this bony lesion to depict more bony lesion margin. And close inspection, this patient also has a skip lesion at the contralateral tibia. So in radiological, we have few differential diagnoses. Always there is aggressive malignant bone tumor. In this case, it is typical of Ewing sarcoma. However, there is no soft tissue mass. Hence, because of the osteoid matrix, we are giving a differential diagnosis of osteosarcoma as well. But both are aggressive malignant bone tumor. But not to forget, if the patient is septic, total white count is increased, CRP is increased, you have to also throw in the infection for differential diagnosis, as osteomyelitis also will have lamellated periosteal reaction. Okay. So with that, I end my first part. Thank you.
Assalamualaikum, good morning. So I'm presenting Miss RT. The first specimen is a paraffin block from the previous biopsy that the private hospital took. So they sent to our center in November 2018. I'm sorry. So this is the block that we received. So we received them, there are small cluster of tumor cells in the background of hematopoietic and adipose tissue with some bony tissue as well. So this is the further magnification of the sample. So you can see there are small round blue cells with minimal cytoplasm. There are some nuclear molding as well. So this is the distribution of the tumor cells showing uniform small round hyperchromatic nuclei with inconspicuous nucleoli and scanty cytoplasm. Minimal nuclear molding is seen. Sometimes in this tumor, we have a rosette formation showing neuroectodermal differentiation, however, not seen in this specimen. and there are some crush artifact as well. And we only did 2 stain over here, but I presume in the private center they did multiple stain as well. So CD99 was diffuse. Usually CD99 is screening for having sarcoma, lah, showing diffuse membranous positivity towards CD99, and negative for LCA. LCA is leukocyte common antigen to differentiate between lymphoma or leukemia. So we did fish in this center, showing fluorescence in situ hybridization analysis with the AWS1 gene. We check it using a fluorescence microscope, and we attach the antibody with a fluorescence punya light, and it will show the split apart lah, showing the EWS1 gene rearrangement. So basically, in sarcoma, we have a 2 gene type of fusion, either EWS1 FLI1 or EWS1 ERG. So in this case, it pick up the EWS1 only lah. So this is the showing the example of the cells chromosome that shows the break apart. We check about 50 cells, tumor cells. And subsequently, after 5 months, they did actually a bilateral tibial resection. And this is the post-chemotherapy changes. I don't have the previous cross because it's a old case. So this one on the left tibia and right tibia shows scattered spindle cell fibroblasts in the background of loose stroma, negative for malignancy, no tumor cells are seen. And evidently in one of the left tibia tissue shows 5% necrosis. So this is the previous tumor cells. However, there is no viable tumor cells seen. All of them showing this pinky eosinophilic material showing is a coagulative necrosis process. This is the difference that you're going to see lah, in Ewing sarcoma versus osteosarcoma. So in Ewing sarcoma, usually the tumor cells are round blue cells. Sometimes can have plus minus primitive neuroendocrine differentiation, positive for CD99, and also positive for NKX2.2, the latest marker. Can be screening or diagnostic as well. This is the osteosarcoma. So osteosarcoma evidently is more pleomorphism. Some are spindle. Occasionally can be pure small round blue cell. So that one will be quite different, quite difficult to differentiate between sarcoma and osteosarcoma. However, in this slide, you can see evidently it will have lacy bony matrix to differentiate between Ewing sarcoma. Another one, if there's minimal scanty tumor cells, you can do SATB2, which is showing osteogenic producing activity. So this is a differential in our side, our point of view in pathology lah. In any small round blue cell tumor, besides lymphoma and also neuroblastoma and also rhabdomyosarcoma. So in children, this is the differentials. The most common is actually Ewing sarcoma. The least of them are all of these now categorized in WHO guideline. However, I won't explain all of this as it is quite rare. Yeah, that's all from me. Thank you.
So we continue with the now after the investigation has been done, which is MRI, X-ray, and also the biopsy. So our final analysis this time is Ewing sarcoma of the bilateral tibia. So what has been done? Initially, this case was being managed by our oncology orthopedic teams. This is some summary of surgical procedure done. Initially, they did the bilateral tibia wide local excision resection, which is resection the whole tumor of the tibia, and replace it with the allograft and stabilize it with a recompleting on April 2019. For the left side is complicated with multiple surgery due to the implant failure. However, it would achieve a full union at the end of 2022. However, for the right side, also same, have complicated with multiple surgery due to implant failure and refracture, and also have complicated with some other issue that we will discuss later in this presentation. This patient also underwent and completed the course of a Euro-Ewing protocol chemotherapy as well as autologous stem cell transplantation in 2019. So in this picture, showing the tumor of over the right and left tibia, and the tumor is assessed as a white local excision, and this is a picture of the tumor have been excised. This is the X-ray post-operatively on AP view of the bilateral tibia and showing the allograft was inserted over the resected part and was stabilized with the recompleting. And this one is the lateral view of the bilateral tibia. However, this patient was presented again with the pain and swelling as well as discharge over the right tibia in 2022 at the time at age of 8 years old. And examination over the right leg, there's a 3x3 swelling over the entire aspect of right leg with punctum, and on palpation is warm, redness and tenderness surrounding the swelling. The swelling is fluctuant with pus discharge. The blood investigation at that time, the ESR is 39, white cell count and CRP is within the normal range. So at the time, I would like to invite Dr. Juliana again to discuss about the radical finding at this stage.
All right. Thank you, Dr. Adli. Okay, Assalamualaikum again. So what we are seeing here is a bit on fracture healing, right? So before we will go and see the radiograph, so we need to understand fracture healing as a general rule. So what happens when there is an acute fracture? It disrupts the blood vessels here in the intramedullary cavity and induces hematoma. This hematoma then induces inflammatory response and activates the immature osteoid bone formation. It will elevate the periosteum and external callus will then form. New blood vessels or new vascularization is tried to connect the bone gap, and later on this immature osteoid bone formation will be more mature, and this bone callus formation will then fill up the bony gap or the bony fracture, and all these vessels will then revascularize and the bone heals. But what is non-union? So non-union fracture is defined as a fracture which fails to heal within 6 to 9 months after injury without any further intervention. Okay, so the classification for non-union, as a general rule, you have hypertrophic non-union, where there are a lot of bony formation, but non-union. Atrophic, which is opposite of it, no absence of callus formation. Oligotrophic is somewhere in between, and also septic non-union. Septic non-union is the diagnosis for our patient. It's because patient has septic parameters increase. But what is septic non-union? It's when the microorganism infect the intramedullary cavity, hence the vessels are reduced in blood supply, hence there is destruction on bony formation to heal the bone, hence leading to non-union. Okay, so let's look at our patient. This is a baseline radiograph post tumor resection. So in June 2020, patient complicated with free fracture. You can see cortical break here at the proximal aspect of both tibia as well as the mid tibia on the left side. Patient then underwent multiple surgery and the bone was corrected, and this is the baseline in April 2022 after 2 years. In December 2022, unfortunately, she developed refracture again, and you can appreciate there is a hematoma at the medial aspect of the mid tibia here. Okay, there is an opacity here together with the cortical break. And in January 2023, there is a subtle finding of the periosteal thickening. You can see here, as opposed to previously, there is none. Okay, it's not related to any cortical break at this region. And there is also subtle finding of now more conspicuous lucency surrounding the implant at the posterior aspect as well as the inferior margin here. These findings raises the suspicion of infection and hence needs to be conveyed to the primary team of possibility of an infected implant. So this hence the diagnosis of a septic non-union. So in this 2021 publication, Cheng Li et al. Investigated 421 surgeries using conventional radiograph to diagnose infected implant. What they found out is only subtle radiographic findings is being found of 11% to 7% only, and it shows radiolucency surrounding the implant and the periosteal reaction, abnormal periosteal reaction, to suggest an infected implant. In such cases, it has low sensitivity for infection but very high specificity. So the recommendation would be a tissue sample for culture and sonication of the retrieved implants if infection is suspected. Okay, so with that, thank you.
All right. So after the radiological investigation, we come up with diagnosis septic non-union of the right tibia with osteomyelitis. So at this stage, the initial measurement of incisional and drainage of the abscess was done, and patient was covered with the antibiotic to treat the local infection before we proceed with more definitive treatment. So for definitive treatment, what be done is we do the sequestectomy with the removal of that bone over the tibia, and also we put the antibiotic cement spacer with Ilazarov fixation for stabilization on April 2022. Intraoperatively, in this case, is the infected bone is removed. So after removal, we leave about 15 centimeter bone defect over the right tibia. So this is an intraoperative picture of the left side showing the infected bone with multiple nidus, and the bone looks unhealthy, as you can see. With over the right side, after the resection of the whole dead bone, there's a leaving quite lengthy space of dead space, about 15 centimeter. So at this point of time, what is the treatment option we can be done for this patient? So actually, there's a few treatment options. Are we going to bone graft it again as before, or we do the dissection osteogenesis via bone transport, or maybe amputation? So what we choose is dissection osteogenesis. Why we choose this? Later my colleague will tell you why we choose them, and he will tell more about dissection osteogenesis, about what the principle of dissection is as well. So this is intraoperative feature of what we do. So we put the Ilazarov ring over the right tibia, and the dead space was, we put the antibiotic cement over the dead space. This procedure is important to eradicate the infection at that time and to prepare the wound bed as well for the next surgery. So this is the radiograph, plain radiograph of the right tibia, AP and lateral view, showing there's a bone cement put over the dead space. So 2 months after that, we proceed with the second surgery, which is removal of the bone cement, and we do the tibia osteotomy for bone transport over the proximal tibia. Intraoperatively, so we find out there's a formation of pseudo membrane encasing the bone cement. However, there's no sign of infection seen. So this is the radiograph 1 month after the bone transport. As you can see on the yellow arrow, at the proximal tibia is where the site of the corticotomy done, and there's a regenerated bone over that side. And the blue arrow is a transport segment. So now the bone loss is reduced to 11 centimeter. Before that is 15 centimeter, right? Then we continue the bone transport. However, this patient had complicated with skin invagination at the middle of the transport. Thus, the bone transport was stopped for a while until the condition of soft tissue is healed. And we proceed with the third surgery to repeat the corticotomy for bone transport on April 2024. So prior to the third surgery, this is the skin condition. The condition of skin looks healed and ready for the next bone transport. And this is the latest radiograph showing there's the regenerated segment of the proximal tibia and the transport segment over with the blue arrow. As you can see, there's a lot of new bone formation over the transport segment from the previous bone transport, and now leaving only up 2 centimeter bone gap. So our aim of this bone transport is to bring down the transport segment until it until the distal tibia. So probably we will proceed with another surgery to do the bone chipping or maybe bone graft to enhance the bone healing and to get a union letter. So this is a picture of the patient with the right Elizarov, and we send this patient to physiotherapy for range of motion exercise. We not allow patient to weight bearing with the bilateral crutches, axillary crutches ambulation. All right, now I'd like to invite my colleague, Dr. Alex, to discuss more about the large bone defect management. Thank you.
Morning to Prof. Jamari, Prof. Savarol, Prof. Reina, fellow lecturers, specialists, colleagues, and fellow medical students. So we are here to talk about the topic on large bone defect. What is large bone defect? So we define the anatomy first. Large bone defect, we define it whether it's at the diaphyseal region, metaphyseal region, or at the articular region. Then we talk about the length of the bone. How long is the defect? And later we talk about whether it is partial, complete, or a complete circumferential bone loss. So all these definition will help in our management. So in the definition of large bone defect for this case, what we say is a defect of 2 to 2.5 times the diameter of the bone, or 50% loss of the circumferential of the bone. So that's our definition for this case. So as you all know, the history and the examination and the X-ray findings that were presented. So and you have seen the clinical pictures of the patient. So what do we do? So our team has laid out the treatment options. So there will be I will go run through one by one and explain why and why not for all this. So we talk about bone graft. If you can see the earlier, there was a bone graft listed. So before I explain what bone graft was, that bone graft we can divide into 4 categories. The first is an allograft. In allograft, the examples will be an iliac crest, proximal tibia, femoral head, or a fibula graft. So in autograft itself, we can harvest the autograft with the vessel or without the vessel. And it has its pros and cons from both the procedures. In allograft, we have fresh frozen, and freeze-dried. So in allograft means that we take the bone from another donor or another patient, and we run through these 3 processes. Okay, so as we go down, the strength decreases, yet the safety or the immunogenicity improves. The meaning it will be less reaction to the body. Next, we have synthetic bone grafts, calcium phosphate, coralline hydroapatite, calcium sulfate. And next, the last is the others, which is a DBM, demineralized bone matrix, and bone morphogenic protein. I'll just explain briefly the pros and cons of each. So as you can see here, firstly is autograft. Autograft is known as the gold standard or the best option of treatment for an individual or anyone with a bone defect or needing a bone graft. Why? Because it is it is from your own body, it is from the patient's own body, which gives a good graft incorporation. It is the least immunogenic. Immunogenic means it doesn't react or it doesn't cause a reaction to the host, and it is strong, so the risk of fracture is less. So why don't we do this much for a large bone defect? Because one, it is a donor site morbidity. It can cause hematoma, it can cause pain, it can cause any fracture over the local area. And the amount, we cannot harvest the entire iliac bone. Sorry. Yeah. we can't harvest the entire iliac bone graft or for this, for example. All right. So moving on is the next allograft. Allograft was used in the patient, if you remember the earlier slide. So if you can see here, this is a donor femur, was taken from a patient. So what is the pros of this? There is a no donor site mobility. This is from patients who have passed away. We can take it in a large amount. As you can see, the entire femur can be used. We can adjust the length. If you want shorter, if you want the shape, we can adjust it. And it sometimes comes with the ligaments, example, the patella tendon or any other ligaments that required. But what is the drawback? Drawback is, like, we have this is from another patient, so we have a potential transfer of disease, and also the immunogenicity depending on what type of process that he has undergone, and it incorporates slowly because it is avascular. Next, it has a rejection rate if the immunogenicity is high. There's a risk of fracture, non-union, and osteoarthritis if at the articular region. So synthetic bone grafts, these are, if you can see here, these are the calcium phosphate granules. So what is the pros? Is sterile, free of germs, available in large quantities, and we have many options as seen before. And it has osteoconductive, meaning it lays a layer of scaffold for the new bone to grow on. And it can also be combined with antibiotic. Excuse me. So if you see earlier, if the patient, for example, the patient we use an antibiotic cement earlier, we can use this together. But what is the drawback? It doesn't contribute to any stability. You can see it's very small, it's very thin. So you need to supplement it with something. And also the reabsorption, that means the body keeps it and it takes time for it to be dissolved in the body. Lastly is the others. Others is Lastly is the others, which is the DBM and the BMP. Is two good properties which has osteoinduction. It can induce new bone formation, and also it gives a good layer of scaffold through osteoconduction. However, its mechanical stiffness is low. You can see it's like a paste-like, and it also needs to be combined with some other material. So back to this question, what do we do? So what are the options? So I run through the options first. We have vascularized fibular allograft, all right? Vascular fibular allograft or autograft. So this one means that we take the fibula from the patient. This is a pictorial representation. We take the fibula with the vessel, the peroneal vessels, and we incorporate it into the tibia, where the bone, this is the bone defect. We incorporate it into it, and we wait for union. So this means that we are taking a fibular bone that is alive, and we help with the angiogenesis, meaning the new bone formation, the blood vessel, all is faster. However, why did we not do this for our patient? As you know, this patient has been diagnosed with Ewing sarcoma, and it's on the bilateral tibia. So if you remember, the patient is on the tibia, the Ewing sarcoma. So why do we don't take the fibula? Because we don't want to cause any tumor seeding to another component. So even though patient has already gone through chemotherapy and surgery, we need to be cautious to avoid any other tumor seeding into other compartments of the leg. And patient already lost a tibia, so removing a fibula will also cause more morbidity to the patient because it's at the same location and it is bilateral tibia. So moving on, our next option will be a limb shortening, and later we lengthen it. So this is a pictorial representation of the defect, and then we bring down this proximal tibia down to the distal tibia, and we lock it with a frame or a plate, and later we lengthen with a corticotomy. Later I'll explain this picture E. But in this meaning, we just shorten the whole limb, So why did we not do this for our patient as well? Ideally, this whole shortening should be a bone gap of less than 2 to 3 centimeter. We have a patient of 11 from the top all the way to almost to the distal end. So when we shorten acutely, what will happen? The muscle will shorten, the neurovasculars will shorten. This will cause kinking, this will cause vascular insufficiency, and also the tension of the muscle will be reduced. Thus, the limb becomes non-functional and is a risk of gangrene. So I repeat again, we can only do acute shortening in a small bone defect, not for a very large bone defect. So, like what my colleague said, we did a distraction osteogenesis via bone transport. Lastly, amputation. I explain now why we didn't do amputation is because we can give the patient a chance. The patient can and seem to be responding well to the initial treatment. So, amputation will be our last option if all others fail. So, we choose this. This was the bone defect from the earlier picture. So this is a bone cement, okay? And then we did a corticotomy over here. So this bone cement, why did we put it here? So that it forms a pseudomembrane to prevent any soft tissue to occlude in this area, because we want the bone to run. We want the new bone to be in this compartment. We don't want soft tissue, we don't want fibrosis, and to hinder the new bone growth. So again, why? Because initially, why we choose osteogenesis, why we choose distraction osteogenesis, is because it is previously a failed allograft treatment because of infection. So we did a musculate technique, like this is a musculate technique, meaning we lay down a bone cement. Then we do, okay, so distraction osteogenesis, why do we do? Is because when we do a distraction osteogenesis here, this area where the new bone forms, it will also help in angiogenesis. That means new blood vessels can also form during the distraction and during the transport. Thus, these are the principles I run through very shortly. The transport we transport from proximal to distal about 1 millimeter per day, and using the Elizarov. So we have to do a corticotomy over here. So you can see this picture. This is a pictorial diagram again. We do a corticotomy. Okay. Once we do meaning what is corticotomy? We break the bone. We make a break in the bone, but we preserve the periosteum and we preserve the marrow. So we do a low energy corticotomy, and then we start distracting transporting the bone down. So after we do, this is in the latency phase. After we do the corticotomy, about 5 to 7 days, then we start the 1 mm per day transport. So we want the bone to go distally. And then you can see here there is new bone formation. However, this new bone formation is once it is formed and once we achieve the length, we stop the transport, we lock it, we wait for it to consolidate. What it means by wait for it to consolidate, we wait for this color to be as white as this. All right, the opacity has to be the same, and then we know that the union or the new bone is strong, and we can decide whether we want to remove the external fixation or not. So again, this is a pictorial representation for our case. We have a bone defect. For example, this is our patient's bone. Sorry, we have a bone defect. So we do a corticotomy here, meaning we break the bone here, and then we transport this segment, this whole segment, we transport it down, and then we want it to dock here. And when dock here, later we will either plate it or either use a bone graft distally. So what happens to the top? There is new bone formation and new blood vessel formation. So all this promotes bone formation, angiogenesis, and it eradicates the infection. Why? Because new bone formation, new inflammatory cells can go to the area. Thus, this whole process eradicates any infection that is surrounding or at the bone region. So you may see that we have a gap here, but through what's happening, there is new bone formation here. Then we wait for the bone to heal, to strengthen, and then we can remove all the implants outside that is at the patient. So this is our patient. Currently, we have a Ilizarov external fixator. We have a proximal bone. This is the native bone. This is the area of new bone formation. Okay, you can see a lot of callus here. And then this is the previous bone that has already been lengthened and consolidated slightly here. And the remaining bone gap is about 2 to 3 centimeter over here. And this will require a second surgery to make it unite and to have this entire bone to be, entire limb to be functional. So in summary, this is what we did for the patient. As you can see, we have a size defect of more than 6 centimeters. We have no major soft tissue problem, for example, any tissue loss initially or any major tissue loss. So what we do, we stabilize, observe. Patient has a metaphyseal region bone defect. So we stabilize it using a circular frame, which is an Ilizarov frame. And then we do bone transport. So this was our treatment plan for the patient, and which she is undergoing this now. So my conclusion for this discussion and this case, bone defect we have multiple ways to treat a bone defect, multiple methods to address this bone loss, and it has to be patient-centric. Each patient is different, and it has to tailor specifically to the patient's current condition, infection status, and even the patient status as well. Both, this is a pediatric case, so the patient, the mother, father, and all any family members involved should be explained and understand the process, because this is a lengthy process. As you know, it's from 2018 until now, meaning from treatment and also until the whole entire management. So what is our aim for this patient? We want to aim union of the limb, and we want to give her a good functional outcome, meaning she can walk without aid and she can perform her daily activities, such as going to school and even eventually able to work. And these are my references. Thank you.
Okay, thank you for all the presenters. We have 10 more minutes. You can ask any question to the presenter if you have any from the floor before we proceed with the Kahoot. Any questions? Okay, Prof. Baru have a question to Dr. Alex.
Hello, test. Okay. Excellent presentation to all of you. Dr. Alexander, what's the advantage of a circular external fixator in terms of when you have a bone defect or deformity as compared to a uniplanar? Because uniplanar is very commonly used in trauma.
Thank you for the question, Prof. So I show from the picture. Okay. So it's a very good question. So in uniplan, this is a uniplanar, which is a monorail system, and this is an Ilizarov. Ilizarov means it's a ring fixator. So the advantage goes by the name itself. The uniplanar is able to control a single direction of bone growth or alignment. However, if you put a ring, we have a 360 control, because we fit them with wires and also with all the shunt speed. Thus, we can control the alignment in axial, sagittal, and coronal plate. But in comparison to the uniplanar, it's usually in only the coronal plate. So it gives more stability if it's a circular frame compared to a monorail.
Okay, I have one question to Dr. Adli for the benefit of our medical student in this hall. Just now you mentioned in the treatment of your patient white local resection. Can you elaborate on what is white local resection?
Okay, thank you, Prof. Jamari, for the question. So the principle of the resection of the tumor, we can divide it into several types. So it include the white local resection lah. So first is the intralesional, which is we remove the intralesion of the tumor. Next is a marginal incision, where we remove the tumor at the reactive zone. And yeah, for the white local extraction is we remove the entire tumor together with normal cuff of the tissue. And the last is the radical resection, which is remove the entire compartment. Thank you.
Just to add on what Dr. Alex answered for Prof. Sabaro's question, which is correct, short and sweet. Just the fixator that we use for lengthening or transport, there are few types. There are ring, there are monolateral, unilateral, and also there's hybrid. So all depends on the type of or the length that we need to transport it. So in terms of long segment transport, the best or the most accurate transport can be done by using ring. The thing about ring is it's a bit more bulky compared to a unilateral. We have some sizes which is appropriate for kids, so small type of unilateral. We also have that, but for this patient, if we use unilateral, it will be difficult because the segment is very far. So even with a ring, sometimes the transport can deviate. So to answer what Prof. Sabaro asked, for this patient, the ring was chosen because the segment of transport is very far. Okay.
Okay, I want to thank on behalf of the Ortopedik Department to Dr. Juliana, Dr. Syed Nabil, and also Prof. Rina for joining our CPC. Medical student lagi tak? Cuba angkat tangan medical student. Ada? Okay. Kalau ada Kahoot ni ada hadiah percutian ke Langkawi 2 hari daripada Dr. Fazli. Okay. Okay, so